When reading chest trauma, please bear in mind that the patient here may have multiple chest trauma. For instance, in order to get pulmonary contusion, for instance, this is the actual bruising, actual injury to the lung. Now, before that happened, of course, the blunt or penetrating force must go through the chest wall, meaning the patient will have not only bruising on the chest wall, but also on the bone. I'm talking about the ribs. Ribs may be fractured, and depending on the severity of the fracture, it may be non-displaced or displaced, and the patient may puncture the lung, causing a contusion, or it may also create a flail chest, depending on how many pieces of the ribs are, how many sections of one rib is broken, or create a pneumothorax and or a hemothorax at the same time. So we're dealing with most probably multiple chest trauma depending on the cause. Let's talk about each one. The questions on the exam will be pretty simple. It will be, how do you know that it's occurring and what do you do about it? So signs and symptoms and interventions. So let's begin with contusion.
Professor,
Yes, sir.
we hear two of you.
Two of me.
Like you're still talking right now.
Is that me?
It's echoing.
Or I don't know why. Because I'm only here once. See, Roger. Because maybe it's because I'm a co-host. Let's try that. You still hear two of me? Hypercoagulability. We have pregnancy. No, I think somebody's playing a. That's not live. That somebody is unmuted and playing something. How about that? You still hear me?
That's better.
All right, so where was I? Okay, questions on the exam will be recognizing it, meaning how do you know the patient has a pulmonary contusion, and then the interventions, what is expected to be done. So let's begin. So this is actual injury to the lung. So what will the patient present with? Here are your signs and symptoms. Key thing to note here is if there is no disruption to the parenchyma, so we're talking about the lung tissue itself, not just the connective tissue part of the lung, bruise resorption is going to resolve without treatment, meaning there's no need for surgery or anything invasive like that. So these are your signs and symptoms. They may not occur at once, stated here. So the injury, similar to secondary injuries you learned in traumatic brain injury. So at first, the secondary injuries may not be apparent. I'm talking about the swelling that follows after the contusion, the inflammation, the exudates. So you may not see it right there at the time of injury. So later, as the lung tissues start going edematous, inflamed, then you'll see the signs and symptoms. Okay, so if once they appear, these are your signs and symptoms. So decreased breath sounds, crackles, wheezing, all related to inflammation and edema. Then they'll start having a dry cough, tachypnea, and then the lung, because now the lung has fluid in it because of the inflammation, so it will now feel dull to percussion. And on X-ray, anything wet will cause hazy opacity on X-ray. And so what do we do? First is oxygen. Fluids and position is moderate Fowler's. Position will be go down, And if needed, the patient would be put on non-invasive first, meaning BiPAP, CPAP, or if the patient has extreme pain because of when they breathe, so resulting in shallow respirations, then they may be intubated and put on the vent. That's it. Rib fracture. This is referring to a simple rib fracture. So the patient's rib here is broken in one place, or it could be multiple, but as long as it's non-displaced, it is a rib fracture. To illustrate that, all right, so a rib fracture, let's say this is your sternum, and this is the rib. So if it's broken, remember the rib is anchored anteriorly here to the sternum. That's your sternum. And then let's say this is the spine, and it's anchored posteriorly to the spine, correct? Please bear with this drawing. So as long as it's broken only in, let's say, one, or it could be multiple, but as long as it's non-displaced, meaning you have a non-displaced fracture, or it could be displaced, as long as the displaced fracture is only on one section, thereby the rib remains attached to the sternum and to the rib, to the vertebral column. There's no problem here because the lung inside will still be able to expand, and then the chest wall will continue to expand. However, there is pain. However, at least the lung is able to expand. So that's what's happening in a rib fracture. Now, let's go to interventions. No splinting. The reason is it will impair chest expansion. So if anything, you can just use your hand or maybe a pillow to splint, because it is painful whenever the patient takes a breath. When the chest wall expands, it causes strain on the fracture, so it's painful. Depending on the injury, so let's say it's non-displaced, they may just allow it to heal, just let the patient limit their movement, protect or guard the area, it will heal spontaneously. If they determine that it's high risk for, let's say, a pneumothorax or hemothorax, or it may be displaced, then they'll have to surgically repair it, just like any other broken bone. So they'll do rods, pins, to reduce the fracture. Okay, nothing different from any other fracture. A flail chest, on the other hand, is where you have multiple, not only multiple ribs involved, but also multiple segments of the same rib. It's not very well illustrated here, but in flail chest, so we have the same fractured rib. So let's say that's the sternum, and then this one is the spine. Okay. Okay, so as long as it is in rib fracture, they were still connected, right? But here now, in simple rib fracture, it was just broken in one place. Okay, so like this one, for instance, like this one. Here in flail chest, you now have a independent section, meaning this section here is now floating. This part here and the rest of this here are attached this one arterially to the sternum, and then this one, this other end to the spine. However, nothing is holding this independent segment here. It will not fall off, of course, because this is you have connective tissue there. So just like when you buy baby back ribs, okay? So if you break that section, of course, it will stay there. However, when the chest expands, since this segment here, this one is not connected to the sternum nor connected to the spine, so this one will be causing the paradoxical chest movement. So as shown on your textbook, look at this now. Since that segment is independent, meaning nothing is holding that, so therefore it will cause the chest wall to cave in during inhalation. So as the lung expands, because there's nothing to hold it, so you have a floating segment there, it will cause the chest to cave in during inhalation and then puff out during exhalation. If you go on YouTube, you'll see actual, it's very obvious when the chest wall caves in as the patient takes a breath. There's like an indentation. So on the chest wall, there will be an indentation during the chest wall caves in. Okay, it caves in literally. So depending on where the segment is, it could be on the arterial wall, it could be on the axillary side, or it could be posterior, depending where the broken independent section is located. So you literally see the chest wall cave in during, or suck in during inhalation, and then it pops back out during exhalation. It will always go toward the opposite side. Okay, here if you take a look at the breathing, so when the patient takes a breath, this is the involved side, so it's the left side. So the mediastinum as well as the trachea will be pushed toward the opposite side. And when that happens, of course, that will be squeezing the large vessels, causing decreased cardiac output because venous return will drop. Therefore, cardiac output will also drop. So this will cause some hemodynamic instability. Obviously, this needs to be repaired. Depending again, the therapy will depend if it's only flail chest and then there's no pneumothorax movement, so most likely there will also lung puncture involved here, so there will be a hole. So we could be dealing with a pneumothorax and or hemothorax at the same time. So the patient will have a chest tube put in, then they'll also need surgery to repair the broken segments. So the signs and symptoms will be the paradoxical chest movement. Obviously, patient will have dyspnea, cyanosis, tachycardia, and like I said, there will be hemodynamic instability. Cardiac output drops, blood pressure drops. Interventions. So oxygen until we can get this patient into surgery. Pain management. If needed, the patient will be given a chest tube. Again, most likely they will have pneumothorax and hemothorax at the same time, and until they can get to surgery. So here's surgical stabilization. Until they get to surgery, you'll have to support the ventilation. If needed, they will have to be intubated and put on a vent, all depending on the severity. For those who are in the military here, this is quite frequent. Okay, a patient gets squished on a steering wheel, for instance, in car accidents, or let's say you got mugged, for instance. So this can occur in trauma victims. Any questions on rib fracture and flail chest? Okay. Let's go down to pneumo and hemo. This is the presence of air, pneumo, and this is the presence of blood in the pleural space. So this is not inside the lung per se, but although there will be pulmonary contusion as well, because in order to puncture the lung, of course, you injure the lung. So on top of the pneumo or hemothorax, you may have pulmonary contusion, except in the case of spontaneous pneumothorax, which is common in COPD, chronic COPD patients, as well as certain individuals, not necessarily smokers or COPD, but you've seen tall, lanky people. Do you know anyone like that? They're really tall and skinny.
Like basketball players?
They can, like you saw, who's really tall and lanky? Kevin Durant, when he first entered the NBA. Yeah, kind of
Okay,
like
Kevin Durant, yeah.
yeah. So that body structure is prone to spontaneous pneumothorax. They form blebs. Blebs, the best description I can give is they're like blisters on the surface of the lung. So they form blebs like that, and these blebs eventually rupture, resulting in a hole in the lung. So what happens is it's better with a picture. So I'll just come back. I'll give you that picture after.
Professor, oh, I'm sorry. Well, I was going to ask, what would cause them to get blebs like that? Like, what would cause them to get blisters on their lungs?
I don't really know. It's just common. All I know, I mean, there's probably a reason, but as far as I can remember, it's very common. Most of the patients I see with the spontaneous pneumo look like that, male or female. Either they're all tall and very skinny. So supermodels are prone to spontaneous pneumothorax. Now it's called a simple pneumothorax if the hole or wherever the air is coming from that is now collecting in the pleural space is coming from is if it's leaking out small amounts of air, meaning the way the pneumothorax developed is slow, is called just a simple pneumothorax. However, if it's tension pneumothorax, meaning the development, the onset of that is either so fast or you have a really big hole out of the lung. Or it doesn't have to come from the lung. It could be, let's say, a stab wound. Perfect example is an ice pick, for instance. Okay, so if you use a pointed instrument like that to stab somebody in the chest, it seals the tract. So when you stab the person, it causes bleeding and some air to enter when you stab the victim. But when you remove the instrument, the weapon, it closes the tract. So now you have air and bleeding in the thorax with nowhere to go. Okay, so that is an example of a tension pneumothorax. Now the symptoms, let's start with the pneumothorax. So there will be no breath sounds on the affected side because the lung is unable to expand. So let's say this is your heart, and this is your mainstem bronchus, and then this is the right, and the left is the lung. So we have the pleura. The pleura is here. So the pleura has two surfaces. it has a visceral side and a parietal side. So between those is, this is of course the space, okay? The space here has a small amount of fluid called the pleural fluid. So this is where the air, blood, or any fluid will collect. So you have either pneumothorax, meaning there's air here. So there could be, let's say, a bleb that ruptured, so you have a hole, so air escapes out there, but then your chest wall is intact. So there's nowhere for that air. So with every breath, some air escapes and gets trapped in this space right here. So eventually that air will accumulate and occupy more space, collapsing the lung. So the lung might only be able to expand this much. So this obviously collapses the lung because the rest of the pleural space is now filled with air, blood, or water. This is, it could be hemo, blood, could be a combination of both, could also be chylo. Chylothorax is lymphatic fluid, common in cancer patients, lung cancer or lymphomas. They tend to cause lymphatic fluid to accumulate in the pleural space. So either way, any positive pressure accumulating here, whether it's liquid or air, because air should only be inside the lung. If you have anything occupying the pleural space, of course, there's now positive pressure in there. The lung cannot expand against that pressure. So you have to remove all of that air, blood, fluid, lymphatic fluid through a chest tube.
So, Professor, the accumulation of this fluid or air is between the visceral layer and the lung itself. It's not like between the visceral and the parietal.
No,
Is that correct?
Yeah. So between the lung and the visceral layer. So in that space right there, there should only be maybe 10 ml of fluid there, very little fluid, just to lubricate the lung. So as the lung expands and collapses, you know, there's, as it rubs against that pleura, there's no friction. Okay, so you only have very little fluid in there for lubrication. If there's a large accumulation there, either the hole could be made from through a injury through the chest wall or from inside the lung. Either way, that needs to be drained out. So the chest tube here, of course, will have to be inserted in that same area. Let's finish the signs and symptoms and then we'll go to chapter 30. So obviously the lung is partially collapsed here. So now we will hear no breath sounds this time because the lung doesn't reach that, doesn't expand to that area anymore. So you will hear no breath sounds. Hyperresonance, because there is no, it's now a blank space. Okay, there's no lung in there. There will be prominence of the involved side, meaning the involved side there will be no chest movement there. There will be no chest expansion, only the other side will. There will be deviation as shown on the picture here in Flail Chest. So there will be deviation of the trachea with every breath. However, if that deviation is extreme, then that is now tension pneumothorax. So the same thing will happen. So instead of having a flail chest, now you have this lung collapsing. So just imagine this one is collapsed, and then you have a lot of positive pressure accumulating here, either air, blood, or any other fluid, anything else wet occupying the pleural space. Of course, that will increase pressure on this because this is now positive pressure. The thorax is supposed to be negative pressure. So the positive pressure will push all of the structures to the opposite side. So that includes the heart as well as the other lung. And once the vessels are now compressed, so you'll see distended neck veins, blood pressure drops, and patient will die in a few minutes. Literally, under 2-3 minutes, they're dead unless you perform a needle thoracostomy. So once identified, you call the physician. They perform an emergency needle thoracostomy. You've probably seen this in movies, wherein the person receives anything sharp, but in the hospital, of course, we use a large bore 18 gauge or bigger needle. It's put in this second intercostal space to relieve the pressure. It is always followed with chest tube insertion because this is only a temporary procedure. Okay, we do not leave that needle in there. So this will be your emergency. It relieves the pressure right away until you can get a chest tube inserted. Chest tube will take another 5 minutes or more to insert. And then of course we will connect the chest tube to a underwater drainage system. Any question? Trauma. All right, let's go to chapter 30.
Go ahead.
They put it under lung cancer because this is part of post-op care. So after any chest surgery, whether it's for the heart, open heart surgery or lung surgery, the patient will need drainage because there will be expected bleeding there. So we need to put a large drain, which is now your chest tube. To help you see where the chest tube is, let's watch a short video.
The placement of a chest tube is to identify the insertion site. The insertion site is the fifth intercostal space just anterior to the mid-axillary line on the affected side. This can be found by using the nipple level as a landmark for the fifth intercostal space. In females, always be aware that the nipple may be displaced inferiorly due to large pendulous breasts. In this case, remember to stay above the inferior mammary fold where the nipple would normally lie. With the patient lying supine, position the hand up and over the ipsilateral shoulder.
This is only for demonstration purposes, or maybe a non-emergent scenario. If this patient is dyspneic, of course, they cannot tolerate being supine. Most of the time when we insert test tubes in the ER, patient will be upright.
And secure it in this position to keep it out of the surgical field. Surgically prep and drape the chest at the predetermined site of tube insertion. Using a small gauge needle, locally anesthetize the skin and subcutaneous tissue and the periosteum of the underlying rib. If possible, the pleura just past the rib should also be anesthetized. Make a 2 to 3 centimeter transverse incision parallel to the line of the ribs at the predetermined site with a number 11 scalpel. Bluntly dissect the subcutaneous tissue with the scissors or hemostat. Dissect over the top of the underlying rib until the next highest intercostal space is encountered. With the tip of the hemostat, puncture the parietal pleura while pushing just at the top border of the rib. You must always enter the pleural space over the top of the rib to avoid damaging the neurovascular bundle that lies along the groove at the inferior border of each rib. Be sure to enter the pleura in a controlled fashion to avoid lacerating the lung with the hemostat. Once inside the pleura, spread the hemostat widely and withdraw it while still open to create a sufficient opening in the pleura for the chest tube. Before inserting the chest tube, place your finger into the hole of the pleura. Move your finger around 360 degrees to confirm correct location in the pleural space by feeling the lung and making sure that there are no adhesions or impediments to placing the chest tube. A large chest tube, a number 36 or number 40 French, is used in trauma to allow for the evacuation of blood and clots.
All right, you see these holes, right? These drainage holes are referred to as eyelets, E-Y-E-L-E-T-S, eyelets, like small eyes, on the chart that we will be discussing when managing the chest tube. So when they say eyelets, these are the eyelets that we're referring to.
Clamp the proximal and distal ends of the tube before insertion. The distal clamp will keep any blood from rushing out before it can be connected to a collecting chamber. The proximal clamp will assist in chest tube insertion, but cannot always be necessary or helpful. Advance the chest tube into the pleural space to the desired length.
All right, so therefore, if you see eyelets here like this, is that good or bad?
Bad, because this is going to be leakage. I mean, it should be inside. It should be.
Yeah, so the eyelets should be inside, because if these are out, remember we have positive pressure in the atmosphere. Air will get sucked in here because we have negative pressure inside. So air will enter the pleural space, creating increased positive pressure here. The patient develops a tension pneumothorax. So you should never see eyelets. When you see eyelets, that is a call the doctor situation. So you call for help and then you cover this with dry gauze in your hand until help comes.
The drainage holes should be well inside the chest cavity to provide a proper seal and prevent leakage. The chest tube should be positioned posteriorly and aimed superiorly in the chest cavity. This will allow for maximum drainage in the supine position. It may be possible to see fogging of the chest tube with expiration, and it may be possible to listen for improved air movement on the affected side. Connect the end of the tube to an underwater.
So this is now this end here, this is the chest tube, and this end here will be connected to, this is a 6-foot long tubing connected to your chest drainage system. So here is your collection, this is now your chest drainage system. So our commercial drainage systems, they package the 3-bottle system into this. Can you see this picture of Atrium Oasis? Yes, no. Okay, so this is now the packaged commercial product. It's now disposable. Or this one, this is a wet setup.
You don't see the picture.
You don't, okay. Here is the Atrium Oasis. This is now the commercial product. So, but the system is still based on the 3-bottle system. So this is bottle number 1, 2, 3. Bottle number 1 is where your fluid is collected. Bottle number 2 is your water seal. So this is your air trap. So allowing air to escape and not come back in. So the principle is the same. The concept is just like when Miss Huertas is in a pool, for instance, she farts, so air can get out of the pool, right? So she'll have some bubbles there and then scare people away. However, if Basam is above here on the pool, Basam is not in the pool, Basam is here. If Basam attempts to fart into the pool, he cannot do that because air always rises and you cannot put air through water, correct? So the concept is simple. So air escapes through water, but it cannot, it's impossible for it to come back in and re-enter the patient's chest. So the water seal is extremely important. So in the event that this patient is disconnected from the system, you have to create a temporary water seal for this protection right here. So you need this as a protection from attention pneumothorax. And the third bottle is a suction control chamber. The name again of the third bottle is a suction control chamber. It does not apply suction. It's a freaking bottle. It does not apply suction. However, it can control the amount of suction that the patient will receive. I'll explain how shortly. So now they package all that into this. So they have bottle number 1, which is more efficient because the glass bottle is capable only of 1 liter maybe. This one can hold up to 2 liters. The Pleurovac series are way bigger. Those things are huge. They can hold up to 3 liters. And this is now your bottle number 2. This is your water seal. When you fill this with the recommended is sterile distilled water. It comes with a kit. However, they will evaporate eventually. So you may add, if the level goes down below this 2 centimeter mark, you can add more sterile distilled water in there. We do not use saline because if it evaporates, of course, saline will leave salt particles when it evaporates.
Crystals.
Right,
Yeah.
precipitants, right. If you see also there's a blue dye. So when you inject the sterile distilled water into this chamber, it turns blue. There's a dye here because otherwise it'll be impossible to see if it's clear. You won't see the movement of the water if it is clear. So there's a dye in here, and it'll turn the water blue. There is a plastic ball inside here. It's up here. It should be down here. The ball will just help you also visualize the movement of the water, because this is supposed to be, remember, this is attached to the chest tube, right? So if the patient, imagine the chest tube is in the pleura. It's between the visceral and the visceral layer of the pleura and the lung. So every time the lung expands, so therefore as the lung pushes against the tube, against the visceral side of the pleural sac, it will push all the air, water out. So therefore when it does so, the liquid is contained here, but the air escapes through the second chamber, causing this water level to rise during inhalation and then go back down and bubble during exhalation. So as the patient breathes, so you see this going up and down, up and down. Inhale, exhale, inhale, exhale. Okay, so when you look at somebody, for instance, your partners, you look into your partner's eyes so you can see their beauty, right? So you can see, you can see their heart or their soul through their eyes, right? That's very romantic. Okay, the eye is the window to your loved one's soul. This one is the eye into your patient's chest. So whatever happens in the second chamber, in the water seal chamber, will be reflecting what's happening inside the patient's chest. Okay, I'll show you again later when we get to the chart. This setup is dry because the suction control chamber is dry. There's no water here. The suction chamber in this model, so this is a dry setup because whether it's wet or dry is determined by the suction control chamber, the third bottle. Again, this is bottle number 1. It has 3 columns. This is bottle number 2. This is your water seal. And this is your suction control chamber. It's dry because there's no water in here. So you see the dial right now, it's dialed to 20. So this patient is receiving 20 centimeters of water worth of suction if you attach your suction tubing here. So you still need a external suction source, either the wall or a portable suction. And as long as, again, this is dialed to the correct setting, that's the amount of suction the patient will receive. The other difference between the wet and the dry, besides this one is dry, the dial, by the way, is controlled by a ring over here on this side. So it's like the volume on an old radio when you change dial on an analog radio. So there's a dial here which turns this from 20 to 30 to 40. In a wet setup can only give a maximum of 20. So besides being wet or dry, the other difference between the two is this one is capable of up to 40 centimeters of water suction. The wet one can only give up to 20. In the absence of an order, the default order should be 20. We usually apply 40 or 30 in large pneumothorax or large hemothorax. Usually trauma patients require that much suction. But most patients we see on the med-surg floor, unless again you're in a trauma unit, is 20. This is a wet setup. It's not very good. I saved a bad picture. Anyway, so this is your bottle number 1. Just still have 3 columns. And this is your bottle number 2. No difference there. But see here, instead of that dial, you have this wet column right here. So you still fill this with sterile distilled water up to the 20 centimeter line. It's not very clear, but this one here says 5, 10, 15, and 20 centimeters. How is it measured? So the height of the water here, which is 20 centimeters high, is the amount of pressure being applied to the patient. The concept is, let's say you're at for those who have children here, you've been to the Ernie pool at Sesame Place, right? So when you're wading through the kiddie pool where Bert and Ernie is at, it's only ankle deep. So when you're walking there versus when you're walking in the adult pool or in the lazy river, for instance, wherein the water is waist deep, which one do you think is easier to walk in? The one in this is ankle deep or the waist deep water?
The ankle.
Yeah, so that is the pressure that you feel there when you walk on ankle deep water. That is the resistance that your feet is walking against, your legs are walking against. That's the amount of pressure that we are applying here. So the higher the water, the higher the height of the water, the higher the pressure. So 20 centimeters high is the amount of pressure that the patient is receiving. One disadvantage here is this water, of course, will evaporate. When you connect this, the suction tubing here, it won't suck the water because the tubing never dipped in here. It's not like a straw that you dipped in here. So the suction is applied, there's about, I don't know, 5 inches here between the top of the water and the suction source. So it never touched the water, so it won't suck the water out. However, when you apply the suction, it will cause this column here to bubble constantly, which is expected. It's supposed to bubble, meaning if you turn off the wall suction, it will also stop bubbling. Or if you kink the suction tubing, there will also be no suction. So therefore, if this column right here in a wet setup stops bubbling, meaning the patient is receiving no suction. But again, the height of the water will determine how much suction the patient receives. So let's say the doctor orders the usual 20 centimeters of suction. 8 hours later, because of the constant bubbling, the water evaporated. It dropped down to 18. Several hours later, it dropped down to 15. How much suction are you applying to the patient?
Can you say that again, Professor? I couldn't hear.
All right. So during the therapy, you filled it with 20 centimeters higher, exactly 20. So at that point, the patient is receiving 20 centimeters of suction if this is applied to the suction and this is constantly bubbling.
Yes.
But because the water evaporates eventually, so 4 or 8 hours later, the water level dropped to 15. How much suction is the patient receiving?
15.
15 centimeters of water. So therefore you need to add more
15.
water. Yeah, so you need to keep adding water as the water evaporates. Again, it has to be bubbling in order to be there to be suction, meaning no suction source, no bubbling, no suction on the patient. But regardless, so let's say the wall suction is turned up to 120 centimeters of water suction on the wall, or the portable suction. You turn the dial, the setting to 120 centimeters of water. On the chest drainage system, this one is at the 20 centimeter mark. How much suction is the patient receiving? The wall is at 120.
20, it doesn't matter.
Very good. So what controls the suction again is not the suction source. It's the water level
Third bottle.
in the third column. Or if it's a dry setup, it's whatever you dialed here. So it's not the wall suction. So if you connect this to suction, you put the suction at 200, doesn't matter. Whatever dial you put here is what the patient receives. What the too high suction you'll put the wall at will do. So let's say you put the wall suction to 150. All that does is evaporate the water faster. I've heard the doctor say, because I lowered it down, and then doctor came in, and he was an older doctor, and then he told me, no, why did you turn that down? Turn that up because the bubbling won't be heard at the nurse's station. Yeah, that's how we know it's working. We need to hear it bubbling. Who the hell hears that if you're at the nurse's station? It's not like it's in a loudspeaker. All right, so that was the most ridiculous comment I've ever heard. But anyway, he was old and I respect my elders. I did not give any comment. I said, yes, doctor. Okay. All right, any questions so far? Let's go now to your nursing care.
Actually, Professor, I have 2 questions.
Yeah, go ahead.
So the first is a simple question, which is when you say the amount of suctioning, like let's say it's set on 20, is that the strength of the suction?
Is that
Like, what do you mean by amount of suction? Is that the strength of the suctioning?
The amount of pressure, because when you put somebody on suction, there is a low, moderate, or high suction level. Now, how much?
So it's like a strong. The higher is the stronger. The
Yes.
stronger suctioning. Like
yeah. How much pressure? Yeah. How
okay.
much pressure do you want? Okay. So the default again.
Now another. Oh, sorry.
Okay. So the default order for non-traumatic cases is 20. So most likely, if you're on med-surg floor, ICU, these are all 20 centimeters. Again, exceptions are for trauma patients. We're dealing with large pneumothorax, large hemothorax. That will be the time you use up to 40. So you will, you will know which package to pull out. Meaning, if it's regular, you just grab the either dry or wet. But if it's you need higher suction, you have to use only the dry, because the wet is limited to 20.
That was actually my second question. When do we use why do we ever use the wet one? If the dry one has more capability, let's say, so might as well just use the dry one. When do we decide to use the wet one?
I don't know who invented it. It doesn't sound very practical to me. That's all I'm gonna say. But this is a business. They need to sell something. So I guess.
I mean, is there any advantage that the wet one has over the dry one?
Honestly, if you ask my opinion, I can't think of any. It's all disadvantage because it's a lot more work for me because I have to monitor that water level because it will evaporate.
Yeah. Okay. Thank you.
I don't like the wet one because I have to keep adding water. All right, so here's now our patient with a chest tube. So they have trauma regardless of what's in there, air, water. The position of the chest tube also will determine that. So this one higher is obviously a pneumothorax, whereas a hemothorax, a chylothorax, pleural effusion will be lower. Okay, for obvious reasons. Air always goes up, so the air will be settled up here in the upper part of the chest. So the chest tube again is between the visceral surface and the lung. So here is your pleura. So the description here is like a balloon, an inflated balloon that you put your fist into. The fist in this example, of course, is your lung. So that's the shape of your pleura. And that's where our air is located at. So we put the chest tube and then we connect that. The patient can have multiple chest tubes if they have, let's say, both. So they'll have two. They may be connected to separate drainage systems, or you can use an adapter so that they'll be connected to the same chest drainage system. It doesn't really make sense having them on separate because in this example, one is only removing air. So it doesn't keep the air escapes out of the system. So you really are just worried about the volume, the water here, the liquid. So here's another one. If the patient has extensive lung surgery, they may put two separate tubes. Again, depending if it's air or blood, they may be in separate chest drainage systems or the same. This is the Pleurovac Series. These are large. Look at this. This thing can hold 2,500. These are the earlier models. This is old but still very useful. So same thing. You have 3 bottles here. Bottle number 1, 2, and 3. All right. The system doesn't have to be on suction 24 hours. The patient is encouraged to ambulate. Ambulation, as you know, will prevent a lot more complications than keeping this patient on bed. Lung expansion is better. You get less chance of pneumonia if the patient ambulates. So they can be disconnected from suction. In that case, we're just draining air and liquid via gravity because it's still possible. But whenever they're in bed in their room, it must be connected to suction because they're not moving. So it will facilitate the drainage when connected to suction. I mentioned that it's 6 feet. You cannot cut this. It's standard 6 feet. So there's likely going to be some dependent loops here. What do I mean about that? So for instance, this is your patient's bed. Patient's here, chest tubes here. So it will be, the drainage system is here. Now the bed isn't going to be 6 feet long, obviously. This is your drainage system. It has a kickstand. Okay, so this is your chest drainage system. Because the chest tube is here, so let's say the chest tube hangs out that, and now you have your tubing. So forget this line here. So this is your tubing. It's 6 feet long. So you most likely have a dependent loop like this one. If this is draining blood, for instance, if it's in this position, so it's going against gravity, right? There will tend to be pooling of the secretion here. So the blood, especially if it's bloody, if you didn't make rounds and you didn't hang this loop here on the bed, because you're supposed to coil this on the bed. So whenever possible, when you make your hourly rounds, you walk in here, you see this drop. So you pick it up and put it on the bed. So you coil it on the patient's bed. That way the position will be, this is the patient, this is your chest, so that the position will be like this, okay, instead of like this. So you just coil the extra tubing on the bed. That way you have a drainage by gravity. So if we have a loop right here and this thing clots eventually, that means you never made your hourly rounds, because otherwise you would have picked this up. So now you have a blood clot here. Once this will completely obstruct the drainage, what will happen to your patient?
Tension pneumothorax.
Okay, because remember, we're supposed to drain that air and fluid constantly. That's why the tube is there. So you need to keep it unobstructed. It must stay patent. It must stay draining. It must continuously drain. Of course, the drainage will drop the longer this thing is in there, because the only time you'll see a lot of drainage and a lot of air is right after insertion. When you first connect this, probably for the first 8 hours, you'll see a lot of air coming out, a lot of drainage collecting. But after that, it should only be a maximum of about 70 ml per hour. So anything higher than that, that's called a doctor thing, because there's something wrong now. That's too much drainage. That means the patient could be, if it's blood, then the patient's hemorrhaging. Or if there's a lot of air, there's something wrong. All right. Okay, so we know chamber 1 collects fluid from the patient. Warning here, it must never fill to the point that it comes in contact with any tube, meaning, because once it comes in contact, of course, that would stop drainage now. So because your box is full, it needs to be changed before it reaches that point. So if it's a 2500 ml capacity box, then you'll have to replace it with a new one at, let's say, 2300, okay, or maybe 2400 if you want to be that close. But the point is, you need to keep the drainage flowing, okay? Because here, the tubing enters if the tubing when the patient enters fluid, drainage stops. Then that is tension pneumothorax. Another cause of tension pneumothorax, as I mentioned earlier, is the islets. If you see those islets, that means atmospheric air can enter the islet and into the pleura, the pleural space. And then another is if it gets disconnected. Remember the adapter that is where you connect the chest tube to the drainage system, which was the last part of the video we watched. So if it gets disconnected from there, that's another cause of possible tension pneumothorax. Although I can't imagine that one happening though, because we do tape it. So you have to have somebody untape it and disconnect it on purpose for that to happen. Chamber 2. There is a typo here, by the way. This is chamber 2 water seal. Right here on the chart, just before I forget later. Forgot to mention this in the morning group. Right here. I know this is correct. That's the correct chamber. Chamber 3 is correct. Right here. It is in the chart. So here, assess for titling, this is obviously referring to chamber 2. Okay, so please change this on your textbook. This is not chamber 3, because chamber 3 is the suction control chamber, right? Is that clear?
Where does it say chamber?
This is
I'm confused.
under chart 30-12. It's under patient. Under patient, and it's the, actually it's on the drainage system part. So go by patient and then under drainage system, this will be midway. How many bullets is this? 1, 2, 3, 4, 5, 6. Bullet number 6 says here, rise and fall of water in chamber 3. It should say rise and fall of water in chamber 2, right? This should refer to the water system, which is chamber 2. All right. Before I forget that, so please change that one because they will confuse you. All right.
Thank you.
So chamber 1 is the collection chamber. Anything wet stays in there. Chamber 2 is where air escapes. So this will be your water seal or the air trap. So prevents air. Remember Maria's fart and Basam's fart. Okay, so that's where chamber 2 is. Now, as already demonstrated, the water seal must be at 2 centimeters. This one hardly evaporates, but it does. But I've never had to fill it, even if my patients has been there for a week. It's never evaporated. It's really just the suction control column in a wet setup that really evaporates. This one, I've never seen it, unless you have a frequent leak, which is not good. So that would be the only case maybe. So if you have a continuous leak and you never addressed it, so yes, it will evaporate. But if you do your job, that should not evaporate at all. Okay, so check the water level every shift. Make sure your levels are correct. Okay, so bubbling. When is bubbling good? When is it bad? Bubbling depends. Where is the bubbling? If the bubbling is in the water seal, which is chamber 2, it depends. What type of bubbling is that? So the normal bubbling is intermittent. So bubbling should only occur when a patient exhales, coughs, sneezes, or even yawns. Okay, of course the bubbling will occur at the end of the yawn. Okay, so bubbling is seen when intrathoracic pressure is greater than atmospheric pressure, which occurs only when you exhale, cough, sneeze, or at the end of a yawn. And then bubbling should stop after that. So this is only intermittent. So just be a fraction of a second when it bubbles. So that is good. A blocked or kinked chest tube, there will be no bubbling because of course no air or fluid is coming out because your chest tube is blocked. So therefore you won't see any tidling, you won't see any bubbling. When you do see a continuous bubbling in chamber 2, that means there's a leak. There are only 2 places it can leak. Either at the connection where you connected the chest tube to the drainage tubing, you didn't tape it correctly. Maybe you use plastic tape. You should never use plastic tape because that will never give you a tight seal. You should only use foam tape. Foam tape is the same material as the adhesive on a 3M wall hanger. You guys have that at home probably. So if you notice the adhesive on the back of that 3M hanger, the one you can pull to remove it, you pull it down, right? To remove it off the wall. So it's a stretchable foam material. So that will be form a very tight seal around the connection tubing. It comes in different sizes. We have 1 inch, 2 inch, 4 inch wide tape. So that's what you use, both for the connection and also at the chest insertion, because you need to tape that area as well. So that's the other area that could be the source of the leak. Again, it's either at the connection where it wasn't taped correctly or at the chest insertion. Because remember on the video, we did not create a circular incision. We just made a horizontal incision and then so it was a straight incision and you put a round tube through that incision. So it's not a perfect fit. So of course you have a leak around the incision. So therefore you have to seal that area. So how we seal it is to wrap a sterile petroleum gauze around it. So it's sterile. It comes in a foil wrapper. The gauze there obviously is wet because it's soaked in petroleum jelly. Of course, that will turn the gauze yellowish, you know, and it's soaked in petroleum jelly, so therefore it's airtight. Okay, so that's what you wrap around the insertion around the tube as where it exits the patient's chest wall, and you put a drain sponge around it, you know, a sponge that has a slit in the middle. So that's, can you picture what I'm saying?
Yes.
Okay. Okay. So say this is the patient's chest wall, and this is where your tube is hanging out. So you wrap this with petroleum gauze, and then you put a drain sponge. So this is a drain sponge. Okay, so it has a slit. So you put the drain sponge here, it will look like that. Okay, and then so you have your petroleum gauze around here. You put the drain sponge here to cover it, and then you put foam tape over, so you shouldn't see anything here. So all you'll see is the chest tube hanging out, and you have your foam tape all over the whole thing. Dressing changes will depend on facility policy. Some hospitals have it changed daily, some every other day, so follow your institution policy. I prefer examining it every day. That way you can see if there's an infection developing at the insertion site. But again, it's just follow agency policy. Titling, I mentioned this earlier, there should be a rise and fall of the fluid with inhalation and exhalation. If, again, if there is no more fluctuation of the fluid, that could mean that therapy is over. You don't need the test tube anymore, meaning the lung has fully re-expanded. There's no more air. There's no more fluid in there. All right, so that would indicate test tube can be removed. Of course, you still report to the physician because he still needs an x-ray to confirm lung re-expansion. So if that's confirmed on x-ray, he'll take the chest tube out. Regarding taking the chest tube out, it's just, they just pull it out, have the patient take a breath, hold it, pull it out, and then cover it with a just regular gauze, and then the tract starts to close, although it will close in several hours. The patient, of course, will be scared to do that, so they'll probably keep the dressing for a couple days, but it has to be removed sooner or later, because the only thing keeping the incision open is really the chest tube. So once you take the tube out, I mean, it's a clean incision. It's a wound that heals by primary intention, so it doesn't take long to close it. There's no need to stitch it or anything. So the tract closes on its own in after several hours. So we discussed chamber 3 is the suction control. If it's a wet setup, it's usually 20 centimeters. Dry, you can go up to 40. So on chamber 3, which is the suction control chamber, this is the chamber that should be bubbling. In a wet setup, it should be bubbling, meaning if there's no bubbling in there, there's no suction. So to summarize our care 30-12, the first part is the patient. Nothing special here. So you do any other respiratory patient. So you do your lung assessment, lung sounds, vital signs, oxygen saturation. However, you do have a tube, so it's going to be painful. So you medicate for pain. Other complications are, of course, this one you need to see if the patient's having a tension pneumothorax. That's one of your signs. During dressing changes, watch it for infection right here. And sometimes, this is not often, there may be subcutaneous emphysema. All this is air. There's air in the subcutaneous layer. It enters it whenever you have a incision made to the chest wall. So this is common for open heart surgery, also lobectomy surgery. So whenever you disturb and make an incision on the chest wall, there's a tendency for air to seep into the subcutaneous layer and get trapped in there. It's really no big deal. The air is absorbed by the body eventually, but if it's large enough to cause a problem, especially if it occurs around the neck area, causing difficulty breathing, then the doctor has to poke it. Okay, just like popping a balloon. Okay, so to get rid of the air. Here's the islets. And this is common. Patients, of course, this is caused by the tube rubbing against the lung. So just reposition the patient and administer pain medication. Some patients may be on a PCA if it's continuous. So just like, and again, any other respiratory patient, you give them an IS, give them, have them ambulate, don't keep them in bed. Now, regarding the dependent loop I mentioned earlier, so let's say it happened already. We have a blood clot, so we did not get to make rounds. Now we have an obstruction, so we need to get rid of it. So imagine a soft, the tube, by the way, that you connected, the material is rubber. It's the same rubber material as the rubber on top of a vial. So the rubber on a vial, when you stick it, does it leave a hole?
No.
I mean, when you turn the vial upside down, does the liquid drip out of the vial?
No, it's like it repairs itself. Like,
No, I'm talking about
I don't know how to
like
explain.
an insulin vial, a multi-dose vial. Does the insulin drip out of the vial once you puncture it multiple times?
Not really, no.
No, right? Okay, so it's the same material. So as long as you poke this thing with a sharp needle, it will close. All right, it's that kind of material. It's that kind of rubber. In fact, there's a procedure called what is this? You've probably seen it when the doctor inserts a talcum powder solution. What is that called? I forgot the term. Oh my God, I'm getting old. I can't remember.
When the doctor does what?
It happens in patients with cancer, meaning if the cause of a pleural effusion, let's say there's continuous accumulation of pleural fluid in the patient's chest, it's not practical to keep stabbing this patient with a chest tube. So it's better to eliminate the pleural space. That way there's nowhere for that fluid to accumulate. Meaning no pleural space, no pleural effusion. So the fluid, whatever's accumulating there, will just go find somewhere else to go. So usually they'll go to the peritoneum. So at least the patient, this is like a palliative procedure. It's not done routinely. So if the patient has usually end stage, patient has terminal cancer. So it's for palliative care, they'll perform this procedure.
Like shunting?
No, let me research it. Somebody know?
Is it
Pleurodesis. So thank you. So the procedure is called Pleurodesis. It's in the chat. Somebody wrote it in the chat. So just read that. It's called Pleurodesis. So you can do that with the tubing. Okay, so you clean, the doctor cleans it, and then he orders the talcum powder solution, and then he uses a needle, inserts it there, and then administers the talcum powder solution through the chest tube. And then, of course, that will go into the patient's chest wall, into the pleura. Then he'll have the patient turn around to spread that solution. And then it eliminates the space, because it will cause both sides, the parietal and the visceral surfaces of the pleura to stick together. So it's stuck together, no more space, no more accumulation of fluid. Anyway, so how did we get there? Okay, so when you have a blood now in the tubing, and it's clogging your system, drainage is now disturbed, you need to get rid of that, right? So you can't really aspirate it because it's now solid. So now you have to move that into the drainage system manually. If you need to do that, do not strip the tube. Your warning is here. Here, if any tube manipulation is needed, do not strip. You can do gentle hand over hand milking. So let me demonstrate milking. Okay, do you see me? You see me?
Yes.
Okay, so if this is the tube, okay, so I won't strip. Stripping would be like this. This would be stripping. You can't do that because as written here, it will create here your action alert. That will create up to 400 centimeters of water pressure. That's a lot of pressure on the lung. You collapse it. So now you're going to have to do milking. So milking is like this. So you squeeze it. Let's say the blood clots here. So you squeeze that here and then squeeze here again until you move that sucker all the way to the box. Right, so that's what they mean here by gentle hand over hand milk. Where were we? Okay, so do not strip the tube. Just like a Foley or any other drain, always keep it below the level of where you're draining from. We already discussed this, so avoid dependent loops. So if you have loose tubing, coil it on the bed. So you have to do your hourly rounds to do that. Okay, so yeah, you tape it well. We know already about bubbling, what kind of bubbling is expected, how much and where. Titling we discussed. Water level should be at the proper levels, 2 centimeter mark for the water seal and 20 for your wet suction control chamber. Okay, clamping. There are only 2 instances where we clamp. In both instances, clamping should only be done for brief periods for obvious reasons. Why can't we clamp for a long time? No, clamp.
Mention pneumothorax again.
Right, because therefore there will be no drainage of air or fluid because your clamping is equivalent to kinking the tube. Okay, so which brings us to the equipment. Therefore, so if you have a patient with a chest tube, therefore, because leaks can occur, so you should have 2 clamps, Kelly clamps. The same clamps shown on the video, which they use to insert the tube. Okay, so you need 2 of those. They should be padded. So you need 2 padded clamps at the bedside, and you need a bottle of any sterile solution, usually the sterile water, because we need that anyway to fill the box. So it has to be sterile though. You need a container of any sterile solution and a few pieces of dry sterile gauze. Okay, so you need all those 3 equipment at the bedside. We'll need them in case of emergencies. So this is one of the uses of your clamps. So we have a leak on the water seal. There's continuous bubbling on the water seal, so we'll look for a leak. So it's simple. Again, the most common spots are the patient's chest wall, at the insertion site, or at the connection. So at the connection, you So if this is your chest tube, okay, that's the end of your chest tube, and this is the adapter, which is like a Christmas tree, and it will be like this. This is now toward the drainage collection chamber, and this whole section here is what you tape. This section here, you tape it. That way you don't have a leak. So you put the clamp here. If the leak stops, that means this is the site of your leak. Okay, and then you retape that. After that, you tape this as stated. Okay, so don't keep the clamps where you're retaping this. So as soon as you figure out that this could be the source, so unclamp, then tape this. If the leak continues, if the bubbling continues and the water seal continues bubbling, therefore this is not your source. You already fixed it. It has to be the chest wall. So simple as that. So you go, you may also tape here, clamp here just one time. If the bubbling stops, that means that has to be your source, right? Because if it was the source here after you clamp here, this is the patient here. This is the patient side. So if you clamp here, bubbling continues, the leak is here. But if you clamp here, bubbling stops, the leak must be over here at the patient side, right? And then you fix that dressing, make sure it's taped correctly, and then that should fix your problem. The other instance that you use a clamp is when you're changing the system. So this is your old box. This is connected to the patient. It's full, okay? The chambers are full. So prepare the box first, and then you, of course, you have to tape this first. And then when you clamp this connect it to the new box, and then unclamp. Again, please do not forget to unclamp. What's the reason why we don't clamp for long?
We don't want to stop the drainage.
All right.
For a long time, so that we can prevent the pneumothorax.
Yeah, tension pneumothorax will develop. Okay, this one, disregard this. I don't really know how the hell do you empty the box. There's no way to empty these disposable things. Maybe this one is for the 3-bottle system, the glass bottle. Yeah, that would apply, but the commercial ones, those are disposable. We do not empty those things, so you just change it. Okay, we need a sample. So just like a Foley, you know how you get a sample from the Foley? Not from the bag, because it's over the urine there is, let's say it's after, several hours after insertion, you can't use that. So same thing, you can't get the fluid sample from the box. You have to get it from the tubing. So same thing, you just create, but you don't clamp, of course. This is not one of those conditions where you clamp, like the Foley. No, this one, no clamping for this one. So you just create a dependent loop, meaning put the tubing on the floor. That way now you have a dependent loop, then wait for the fluid to gather, and then you clean it, and then you insert a needle to draw your specimen. And of course, these ones are the ones you call the doctor about, because obviously there's something wrong. This one could be bleeding. This one maybe tension pneumothorax, especially if it occurs with this. Now for the emergencies, so chest tube falls out. So patient forgot they have a chest tube, got out of bed, didn't bring the box with them, it pulled out. Now the chest tube is on the bed or on the floor. So what you do is just cover the area with dry sterile gauze. Keep your hand over that, call for help. If the patient's chest tube is still intact, but then it got disconnected from the system. So this is what I mean by there's almost no chance of this happening. But if it does happen, so you lose, remember, you lose the water seal because now the patient is disconnected from the drainage system. So the water seal is no longer protecting the patient. So you have to create a temporary water seal. So this is where that sterile bottle of sterile solution comes in. So you need that to dip the tube in it. So you put the tube in there. There you go. Voila! You have an instant water seal. Or this one. You call the doctor about this because the drainage stops. It can't stop within the first 24 hours. It's almost impossible. So there must be something wrong. Either the chest tube eyelets are blocked. Maybe there's a blood clot occluding all those eyelets, which is dangerous, not good. Or the tube is, maybe it's not the eyelet, maybe a clot is obstructing the chest tube. Okay, so if it stops within the first 24 hours, you call the physician. Any questions? So that's chest tube. We'll start with cardiac next week. Don't forget we have a quiz 5 next week covering from airway management up to chest tube management.